Hello, everyone. Welcome. We appreciate you being with us. We're very excited about spending the next hour or so with you in conversation, as we have some great leaders from around the industry to help us think through and talk through this important topic. I am a director and the chief physician executive for the Chartis Group. We're about 500 people completely devoted to healthcare consulting, with a mission to materially improve healthcare in the world. We're with industry leaders every day, and we're delighted to be able to talk about this topic. Our goal over the next few minutes will be to do some very brief introductions. Many of you may have seen, as part of the registration for this, if you have not, you will soon receive, an article that we've collaborated together with a number of industry leaders, some of which are on the webcast today, and more leaders actually than that, as well as some of our teammates from across the Chartis Group, to begin to assert our overall point of view of what an important topic in space this is. As we all look to improve healthcare, we believe that one of the most important available levers for us each to chase the triple and now the quadruple aim is to find the untapped value within APP expertise. And we have leaders with us today who have done just that. We'll have each of them talk through a little bit of what they've been doing. We hope to engage in Q&A. Each of you should see a Q&A tab on your screen, also a chat tab. Either of those should work. We will be polling you partway through the session, so just a little bit of preview about that to help spur some of the conversation. Next slide. Delighted to have experts with us: Brittany Broyhill from Atrium Health, April Capu from Vanderbilt, Ben Reynolds from UPMC, Susan Stempick from Leahy Hospital and Medical Center. We each read a lot and we have a chance to hear what people say, but this is really an opportunity for us to talk to people who have done things, not just said things. And obviously for them, that also means that they are inside organizations who are bought into the vision of APP value and have engaged them in leaders in some of the impressive work. So we're delighted that they've privileged us with their time today and their commentary. And now we'll just step through the model briefly. If you read the article, you'll see that we've set out in general terms that we believe there are 6 really fundamental keys to unlocking the transformative value that APPs can bring to the team and to the organization, to the industry. Each of these leaders have been active in these areas, and so we're going to now ask them to give us some local insights, local perspectives and examples from the field of how these topics and these keys look through their lens. Next slide. April?
Hi, yes, thank you, Roger. Yes, at Vanderbilt, we have just over 1,400 advanced practice professionals here. And with that many, it is imperative that we have a strong infrastructure for support for this cohort. I am the Associate Chief Nursing Officer. I have an Office of Advanced Practice with an amazing team that each one of us work to support the development and the ongoing support of this infrastructure. We work closely, I work very closely with physician leaders, nursing leaders, of all of the different departments, the different clinics and hospitals, to really make sure that we're optimizing the utilization of advanced practice, but also that we're maximizing the professional practice support of advanced practice, and of course, optimizing the care delivery. Patient care delivery is paramount. But I would really kind of describe the work that I do in 3 buckets, if you will. And the first bucket is one that we don't always love to talk about, but that's the regulatory category. And we work very closely to make sure we have a strong credentialing and privileging program. I serve on the credentials committee as well as our medical staff bylaws committee. to make sure that we are optimizing advanced practice through these institutional initiatives, and that we're able to speak to that on a day-to-day basis as an expert with all of our different colleagues. To that, other regulatory things might be what you might not consider regulatory, but we are a magnet organization here, and there are important elements as they pertain to advanced practice that we are constantly striving to achieve. And then we're Joint Commission accredited. So those things come in and under the regulatory umbrella, as well as our many quality initiatives and our striving to make sure that each one of our advanced practice providers and our teams have specific quality metrics that they are working to accomplish. And then lastly, I think our big expertise comes in the fact that I am very familiar with our state requirements. So state by state, there are some differences in the regulatory requirements for advanced practice. And so that's something that we must be expert in and be able to communicate this with our colleagues, both our state and national requirements for practicing as an advanced practice provider. So that's one category. The second category is really all about staffing and being really understanding and being in tune with staffing ratios and staffing models and ideal models of care based on that particular clinical area. Understanding productivity models, those are all important, but it goes one step further in that we provide clinical consultation to our recruitment team. We do provide input on compensation and benefits, and to really make sure that the structure is consistent and somewhat standardized across our system. In the same category is really the transition to practice. So onboarding and orienting a new advanced practice professional, whether they be a new grad or an experienced practitioner, making sure that they have a good program in place to bring them on so that they can develop confidence in their skill and feel really integrated into the Vanderbilt team. So those are some pieces of that particular category, if you will. And then the last one is all about the advanced practice providers' experience. We want them to be happy here. We want them to enjoy their jobs, be part of the teaching team, and really connect with one another on a day-to-day basis. So we provide a lot of support around having a council and different committees that they can take part in. But we also set up the infrastructure for professional practice evaluation, and also making sure that we have clinical advancement models in place that they can increase and continually grow professionally in their career. So those are some things that we do really around supporting the advanced practice professional and advocating for them as a viable and highly contributive part of the advanced practice and healthcare team.
Thanks, April. Sue, I think you're going to speak to structure and support at Leahy.
Yeah, so an additional piece to add to the conversation, and probably many of you on the call have thought through this in your organizations, is the idea of advanced practice providers being part of the medical staff. And this has become a little bit more of a prevalent conversation nationally in my experience in the past few years. And in our organization, we made this change about 4+ years ago now, in early 2017. And while at the time we were on this journey, the APP community felt like this was really important for kind of a seat at the table component of them feeling really part of the organization. But what I've learned since then is that actually it's much more important than the voting membership of the medical staff. It has changed and morphed and brought forward the culture in our organization. And even before this change, we had a very collegial culture where our APP colleagues were thought of as professionals alongside the physician colleagues. But this has really added that to every conversation that we have, and has provided the opportunity to remind people that APPs are integrated into our physician search committees, for example, and just like April was referencing, into other committees and councils that are important. It is also important as you go on this journey that the stakeholders involved and the timing of this discussion matters. So it is important to think about whether the organization is ready for this, and whom may need to to be a part of that conversation in making the organization ready. But I have found that this integration work is an ongoing journey and not a destination. And we can continue to teach each other all the time that integrating the APPs into the model is just like integrating them into the care model in both the outpatient and inpatient setting. It is more and more important so that we're delivering the care in the most complete way possible.
Thanks, Sue. And I know the leadership sponsorship of the C-suite is critically important for success in all of your organizations, and that you have earned that, and that you have that, and that's a huge part. Ben, not a hotter topic around than care model redesign, and obviously APP Works part of that. Please share with us some highlights from UPMC.
Yeah, absolutely. And thank you for having me on to the Chartis Group. And Roger, thanks for hosting this. This is as you pointed out, is an incredibly important topic. Care model design is something that's incredibly near and dear to my heart because I think it really defines the true value of a clinician leader. When you can take the work that you do administratively and in a leadership role, and then apply it to the bedside where it can really affect positive outcomes. At UPMC, we're a vertically integrated health delivery and finance system. We have an insurance arm as well as our health services side, our providers and our hospitals. And so we try to work in concert to produce the greatest value for our patients, for the protected lives that subscribe or purchase health insurance from us. And so we're very conscious about providing low cost care at the highest value. And what we have here are just some of the work that we have done in partnership with our insurance arm, as well as with our primary care settings to help create the greatest amount of scale to the care that we provide. We have worked to develop advanced practice provider provided specialty care into our primary care settings. I'll use the example of asthma. Asthma is a very highly prevalent disease process. It has a high morbidity and a high economic morbidity for folks. And in Western Pennsylvania, in many of our rural primary care settings, they aren't very close to specialty care pulmonologists that work in managing asthma. And in many cases, they may be in situations where they're not able to travel to go see a pulmonologist that may be some distance away, depending on where they live in some of the more rural parts of our state. And so what we've done is we've trained an advanced practice provider specifically in asthma care. And using evidence-based clinical pathways, working with our academic pulmonologists in the University of Pittsburgh, where they're embedded within the primary care practices to provide advanced care. We found that it decreases emergency room utilization. Using objective ACQ scoring, we found that it's improved the overall control of the disease, and it's a low-cost model and convenient for the patient. They can get access to their specialty care while they're visiting their primary care physician. Access means a great deal to us. We want our patients to be able to get care when they want to seek care, and so we embarked in our primary care arm to support the development of primary care walk-in clinics. And these are extensions of our primary care practice that allow the patients to be seen when they want to be seen. And they're not associated with any particular practice. They're associated with all of UPMC primary care and can accommodate patients when they come in. This has helped us to decrease wait time for primary care visits or for acute care visits, and they are highly associated with high patient satisfaction. The convenience of being able to go in and be seen has been a real patient pleaser. And then sort of the heart of our convenience care model is our virtual space, where we have advanced practice providers in UPMC Anywhere Care. And this is our platform where we're able to provide 24-hour-a-day care staffed by advanced practice providers. And it's free for our health plan members and low cost for everybody else. And we've also been able to leverage all of our telemedicine strategies to benefit in sort of the same way that we have with Anywhere Care, providing the extension of specialty care via telemedicine using advanced practice providers to some of the more remote areas of our of our state. UPMC has 42 hospitals, 900 practices. And so being able to scale our world-class care to as many of our communities as possible is a core mission of ours.
Thanks, Ben, for that very forward-looking stuff. As you said, I think it not only plays well from a patient's point of view in the fee-for-service environment, but is exceedingly important once one gets into the value environment. Brittany, one of the key questions, obviously, with big change initiatives is the question, is everybody aimed in the same direction? I know you and Atrium have done some work around alignment of goals and incentives. Be happy for you to talk to us about that.
Right. So, while most of us did not go into medicine with the eye towards compensation and goals is really one of the key components of building these care teams. So I'm going to outline 3 big things that we did that I think are really crucial for being successful in this space. So first is creating an aligned framework for compensation and incentives between physicians and APP teams is really important for the culture. Number one, how the APPs view themselves and also how physicians see the APPs as true partners and team members because of that aligned framework. If you have an APP still in a model where they're clocking in, clocking out, not on an employment agreement, for example, it changes the way that the APP views themselves as an hourly teammate versus someone in that professional mentality and model. And so really important to align those types of components to create that culture. Second thing is aligning the goals that for the physicians and APPs to the system or medical group goals. You really want both physicians and APPs swimming in the same direction as the organization is. And I highlighted that, it's different for different specialties, but, and you should create individual or group goals based on what the system goal is. So for example, patient experience is a really good one. Really key, especially as our value contracts are moving and putting more weight on the patient experience, and something that's all near and dear to our heart with the patient being at the center of everything that we do. Certainly individual goals in ambulatory spaces where a provider has the opportunity to impact that if you're moving in that, if you're trying to move that needle, but also in some places in inpatient settings where it's not, care is not tied to an individual provider, but really a true team-based effort, important to set a group goal towards patient experience. And then third, I would highlight that when you're creating incentives, we really need to create that goal with the idea that if physicians and APPs work together to achieve that goal, they win together as a team, and they can't win unless they work as a team. And so quality, volumes, productivity, patient experience are all things that we're used to using as incentives for our physicians and APPs, but wanted to highlight productivity as a big one. If you create an incentive model where you have physicians and APPs both on a production model, but you don't have it to where the production model allows the APPs and physicians to work together to achieve a production or volume goal, then you're setting yourself up for competition. And it's not going to be successful. So really important, again, as you start building these incentives and outlining these incentives, if you want true team-based care or for APPs and physicians to work together as a partnership towards a common goal, that you create something where they win together, they lose together as a team. And that really helps build that culture.
Thanks for that, Brittany. Next slide. We all know that medicine continues to specialize and subspecialize, and everyone wants to enter a role fully prepared to be successful. Patients want that, professional providers want that, et cetera. And I think both Ben and Brittany are going to speak briefly to what you've done in the postgraduate mode to help get APPs fully ready to be successful.
Yeah, thank you, Roger, and I'm sure Brittany would agree. This is where, where communicating with like institutions and reaching out and having that network with folks who have done this before has been very, very helpful. I can tell you we've learned a great deal from what Atrium has done. I hope Atrium has learned some of what we've done and put it to practical use. We take the matter of advanced practice provider onboarding and orientation quite seriously at UPMC. It's sort of the linchpin to a top of license autonomous care delivery model. All advanced practice providers, when they come out of school, and a large amount of the incoming workforce are brand new graduates that have a gap between what they know at the time that they graduate and what they need to know to be, as productive and as and successful in practice. And so we've made a significant investment into not just formalized onboarding and orientation, but also postgraduate fellowships. And we talk a little bit about this on the slide here. So most of our fellowships, and I'll say that maybe we only have one that's not a year in length, and one that's actually 18 months in length, are around 1 year. And we've done a lot of internal research on this to understand sort of what the optimal amount of time is in order to get an advanced practice provider to a level of not necessarily expertise at the completion of a fellowship program, but at least at a level of comfort to be able to deliver care safely and at their fullest potential. And we try to harness, or try to couple, I guess is probably better, is a better way of putting it, our postgraduate fellowship strategy with our workforce needs. So we try to matriculate fellows into our fellowship programs based on openings within our employment. I'll use as a shining example our pediatric service line, where if you want to work in one of our pediatric specialty areas, you are enrolled into our fellowship program. That's the only pathway to employment. And so on the first day that you begin working, you're essentially in the fellowship program. It's has structured didactic and clinical experiences throughout the entirety of the year. Because we're interested in investing in the workforce as a long-term asset for us. We're not interested in investing in training somebody who's going to go work at Leahy Clinic, for example. We're interested in them staying within UPMC for the long term as a career. And so we also then try to couple that with the right kind of incentives. And I call this front end, back end contracting. And in the front end, we know that not everybody will be successful going through a fellowship. I mean, there's a particular rigor and a higher level of performance that we expect. And so in the employment agreement that we put into place, we make sure that we're recognizing that they're in their learning status without necessarily a commitment for employment at the completion. And so if they aren't, in this sort of 1 year audition, if they aren't performing at a level that we, that would make them successful as a future employee of ours, then, their education ends, and then they're able to sort of take that education and use it to sort of punch their ticket into whatever their next job would be. But if they are high performers, then that back-end contract comes into place, and we then put them into an employment agreement so that we keep them there, and that they want to stay with us, and hopefully their experience during their training is such that they'll want to. And we've discovered that because if you're matriculating on a rolling basis, that you always have to have your curriculum ready at the drop of a hat. And part of that means that we have to really leverage the technology that's in front of us. Microsoft Teams, we were actually discussing before starting this webinar, has been really helpful to set up different teams, different channels, have our material curated and ready to go when an opening begins, as well as being sure that a lot of our lecture and didactic curriculum is pre-recorded and ready for when we matriculate a fellow into our positions.
Thanks for that, Ben. I do think Susan would probably be fine if you happen to train some folks for Leahy, but that's a different topic. Brittany, share with us the Atrium example around all you've done around training professional development.
Sure. So this could be an entire webinar in itself on postgraduate training. I think Ben would agree. But at Atrium, we've had up to 22 different specialty tracks, and I'm planning on contrasting a little bit with what Ben spoke to, but very similar framework, because we've all collaborated and created these things across the country together and shared what's worked and what hasn't worked. But again, 12 months in length, we've had up to 22 different specialties, and it is really driven by the medical group projected workforce demand. What makes it difficult to not do it on a rolling basis, and we have biannual start dates. So to contrast to Ben, we're having to work to project it in 18 months, what we expect our turnover to be, either through retirements or just moving to a different career path. And so that does create some challenge, but it allows us to start and stop classes together. And we decided to do biannual start dates because of graduation times for PAs and nurse practitioners, so that we have a constant pipeline or stream of folks to fit our medical group workforce demand. So you're never 2 or 3 months away from a new fellow completing their fellowship and being able to enter your full-time workforce. We do, like Ben said, we will put someone under an employee agreement if after their fellowship we like them, they like us, and we have that workforce need. We also offer them a pretty substantial sign-on bonus to sign that contract to stay with us for 2 years. And we've had really good success on retention, but also just overall completeness or wholeness of the clinician. So we teach not only clinical curriculum, but also professional curriculum on how to be a great leader. The networking that they get across the organization is far beyond any orientation program that you can imagine. And we also teach them a QI curriculum or doing quality improvement, because that's so important. And what happens is these projects build upon each other, and it's something that we're really proud of, and it's a meaningful impact that they can have long-term on the organization. So that ROI back to the organization, given that it is an investment, not only are we allowing our APPs to bill for their work because they're fully licensed and credentialed, but they're also doing this QI work that's critical for the advancement of the organization and our flow and processes. I do want to highlight terminology is really important here. You'll hear this debate around the national organizations for advanced practice providers, fellowship versus residency. We at Atrium have chosen fellowship because, again, our folks are fully licensed and credentialed at the end of their formal education and training, and they're choosing, much like our physicians, to go forward in specialty fellowship training, and we think that's important. You'll also hear, well, is this an onboarding program like an orientation? What's the difference in transition to practice versus fellowship? Again, orientation may be a 3-month orientation where you're learning specifics on your specialty or your department. Whereas what we're talking about with transition to fellowship is a deep immersion into not only the clinical training that you get in orientation, but this professionalism, QI curriculum, and networking across the organization versus your individual department. So we have folks, let's say in emergency medicine, that are going to spend time with neurology and OB and critical care, because they're going to see those types of patients in the ED. And it gives them a more well-rounded ability to provide care autonomously at the end of the fellowship because of that. So that's a little bit about our post-grad fellowship. I will say also a key component for our Center for Advanced Practice, we have an academic director of our academic division of CAP, because I think it's important not only for the folks coming in, but for the life cycle of the advanced practice provider that you are focusing on continuing medical education. So pharmacology CMEs, really important for APPs to maintain their certification. And we also do an annual conference put on for APPs by APPs, but also our key physician leaders are involved in that, and clinical folks who are able to infuse their knowledge and cutting edge research that they're doing. But this has been really good because it gives our APPs a chance to not only show what they know and educate each other across specialties, also the networking and camaraderie of our APP group, but it's giving them an opportunity to be on the podium, which gives them an opportunity to then step into the national stage and present some of their work there. And finally, APP leadership development. It was important to our medical group senior leadership, even in the C-suite, that we need to develop our APP leaders. And so part of the Center for Advanced Practice work is supporting that leadership structure that Sue and April have talked about, with doing an annual APP leadership retreat. Like, what do we want our APPs to grow up to be? What do we want to impact as advanced practice providers, and how do we do that as advanced practice leaders? And we partner with something called the Center for Physician and APP Leadership and Education, and also have formalized leadership training for our emerging leaders. So we've got a semester long, if you will, partnership with a local university business school where there are once a week kind of MBA light curriculum, if you will, where APP leaders and physician leaders are side by side learning some of those nuances with C-suite physician leaders and administrative leaders on how to be a better leader. And then there's also mentorship programs for our physicians and APPs, and our APPs are a part of that. So really investing in the APP leadership is what gets you to the next level of being successful in probably all 6 of these components.
Thank you, Brittany. Really good. Sue, as APP numbers have grown, the dollars track with that, and I know everybody appropriately needs to pay attention to the economics and the finances of this aspect of their organization. So happy to hear what you're doing in that regard.
Yeah, so thank you. The way that I like to frame this one is early in my role as Director of Advanced Practice here at Leahy, one of our high-level leaders, the CEO at the time, asked me, they said, oh, your APP workforce is growing by X, but I don't see a commensurate increase in RVUs, and what are you going to do about it? And so it caused me to focus very early in my work in this role on how to teach the organization that it's not just about RVUs. And each organization, of course, measures performance maybe a little bit differently, and we all are on the journey to defining value differently than only productivity. And so, we're living in a time that is certainly a transition in the way that we look at these metrics. So very similar to how Brittany was describing her, the integration of the compensation model and the incentives, we've done something similar here at Leahy. And so integrating the performance management models with the physician colleagues and having more team-based metrics that for us are reported on a very regular basis to the leadership at the clinical division level, including to the APPs. We are not as sophisticated as Brittany's model at Atrium in terms of matching our entire structure together yet, but we have found that raising the conversation that all of these are team achievements has made it much more clear to both physicians and APPs across the organization why we need to care about this. And we have also focused very significantly on those metrics that are for quality. So the patient experience and other quality metrics, both in the inpatient and outpatient setting, to show our colleagues how they are performing as a team. And so one example that I will highlight that has been a unique opportunity for us is we recognized early in when this question was asked of me, we are an academic center, we have a reasonable number of shared visits. It varies by division how much that practice is utilized, and we can talk in a different time about whether that's good or bad or maybe both. But we recognized we needed to objectively measure this. And so we created a process within our electronic medical record where the APPs were able to mark that they were participating in a shared visit. So this process translates to both inpatient and outpatient. We are able to measure the exact number of shared visits and also match that to the CPT code as well as to the specific physician with whom that is a shared visit. That has been very helpful for the APP to not be kind of invisible, if you will, when we're reporting productivity metrics. And so it's very clear that complex visits or a high volume of visits are no longer the output solely of that physician. And that has been really helpful for leaders in any given clinical division to understand where the teamwork support needs to be distributed and to make sure that we can provide the appropriate resources for certain clinical practices or subspecialty foci of large and complex divisions. So this has actually been able to drive operational decisions for us, as well as provide information to inform future staffing decisions and training. So that's just sort of one example of what we thought was uniquely important to highlight the contribution of the APPs, and then actually, frankly, sometimes drive change in the practice model.
Thanks for that, Sue. Certainly a hot topic. We get lots of calls, as you might imagine, from clients or potential clients wanting to think through, talk through different models and their overall economic impact inside the organization as one looks to innovate on the care team. And really important to stay connected with what are some of the more major innovations look like today. April, it is not a level playing field out there across the country. Lots of variability, obviously, and therefore nearly any part of a high-performing APP approach includes advocacy. Be happy if you talk to us about your thoughts around that.
Sure, and advocacy is just as important as the other elements that we've talked about today, but each one of these elements certainly could be a webcast in themselves. It's just fascinating as we learn more and more about advanced practice and how to effectively incorporate them on the patient care team. And so when I talk about advocacy, we immediately go to state and federal legislation, but first I want to just really highlight how important it is to advocate on your own home turf, if you will. Here at Vanderbilt, one of the big initiatives that we set out to put into place a few years ago was to really incorporate a strong advanced practice leadership structure across the system. And so we now have 18 directors over different service lines or hospitals or our ambulatory enterprise, if you will, but they're each over a very large cohort of advanced practice providers within their particular area. And the reason we have so many is because we have a like structure for our physician leaders and our nursing leaders and our business leaders. And we really felt very important, that it was very important to have an advanced practice director on the same team sitting alongside the physician leader, the nursing leader, and the business leader, that they're all working together on their particular clinical area to make sure that they are implementing the very best structure to provide the very best patient care. And without the advanced practice voice there on that team, you're really missing a key element because advanced practice is so prevalent throughout our system. We want to make sure that the advanced practice leader is there as a stakeholder with that leadership team. So that was one important point. And then in terms of every single day, there are so many initiatives. There's task force, there's clinical committees, there are different types of committees that are put together where they really do impact advanced practice in some way. And so it's so important to have an advanced practice professional as part of that committee, whether that be an educational committee, part of the development of a fellowship. We talked about that earlier, or on the metrics team that Sue just talked about, and really having those discussions and being at the table when they're talking about productivity and how do we really maximize that for the advanced practice professional, but also leverage the capacity of the entire team so that we can really provide the very best care. So when we talk about advocacy, we don't always talk about it on an everyday basis within our own clinical teams and within our own institutions, but that is paramount, I believe. But it also extends beyond, and how are we really advocating for advanced practice, but not solely advanced practice, advocating for the patient? And are we advocating on a state level and a federal level to really optimize access to care? I really appreciated Ben's comments about new and innovative models of care, going out into the community, providing care that's convenient, accessible, affordable. That's really where we're moving today as a society. We want healthcare when we can access it and incorporate it into our very busy lives. And so how are we doing that across our communities? And so there are states, there are often laws that are in place that might be outdated that need to be brought up to current to really optimize the access to care, optimize the usage of having an advanced practice provider on the team. So are we really incorporating our advanced practice providers to work to the top of their license, to really work to the top of their education, their clinical training, in many cases, their board certification, if you will, and are we really, optimizing that utilization? And then on a federal level, you see more and more around patient care issues. So are we making sure that we're really providing the right provider at the right time with that particular patient? Are we eliminating barriers, such as making sure that patients can quickly get to the medical equipment that they need, or they can quickly get home health care, or they can obtain care around addiction and reducing the use of opioids or optimizing pain treatment? Those are all things that are very current and relevant topics in our country today. And are we effectively using the advanced practice provider in each one of those clinical topics to really make sure that we're providing the best patient care possible?
Thanks, April. It's great to have your voice and your colleagues' voice who are on this call, this webinar, out there speaking, not just about what we're doing, but why we're doing it and how the industry and society and our patients can benefit from it. We do want to pause briefly here. So you've heard each of the leaders step through some of their local experiences and insights around those 6 keys to having a high-performing APP enterprise and tapping the value. So we have a poll for you, which is of the 6 elements in your organization now, which do you think might represent the greatest need? And take a couple minutes and think about that and provide your answers. And as you do, I'm going to go ahead and get to some of the Q&A, because we've had a few questions come in for panelists. So we want to get to as many as those as we can over the next 10 minutes or so. So a question for Ben: did you create your own fellowships or purchase content from someone else? How did you prioritize? And considering that investment that you've made in those fellows, did you offer a retention mechanism of some sort?
That's a great question. So our fellowships are homegrown. We did not purchase the content. We obviously have a very, very close partnership with the University of Pittsburgh and have a very strong academic core from which we could draw on multiple resources to build our fellowships. The very first fellowship that we developed at UPMC was in surgery. It was one of the first fellowships that was inclusive of both physician assistants and nurse practitioners to train providers in surgical care, and that was out of a need for more providers in that particular area. We then developed another one in critical care because that was a need that we needed more higher performing individuals to be working at. So the prioritization really is a matter of what the need happens to be. We've recently expanded the number of pediatric fellowship programs, as I mentioned before, under some stellar leadership at Children's Hospital of UPMC Children's Hospital Pittsburgh, and it's for, we needed to provide greater access to high level care for children to help decrease wait times and improve access to subspecialty care. As it relates to offering a retention mechanism, one of the things that we have within UPMC is a mechanism for upward mobility we call the clinical career ladder. And once you've completed a fellowship, the fellowship can help serve to check a box in the minimum criteria to advance within our clinical ladder. It's certainly a big topic, and we can discuss more about some of those advancement opportunities at our various institutions. But we do incentivize that for advanced practice providers to stay within the organization upon completion of their fellowships.
Thanks for that. Amy, do we have poll results to view? Interesting. We have lots of need in lots of places. Very interesting how on the money some of those are with each other. So thanks for that. We'll debrief after the session kind of what we think about that. I think it means, at least in part, people recognize the value of each of those keys, and to contemplate getting any of this work done, particularly at the transformative level, without being active in each of those areas is a pretty difficult task. So thanks for that feedback. We'll take those and think about them a little bit. More questions have come in, probably more than we're quite frankly going to be able to get to, but a couple. Brittany, a question around your discussion of winning together. Are incentive models outlined in your APP employment contracts? Can you talk a little bit about the design of that, or any other comment to make about winning together?
Sure. So what I mean by win together is the physician nor the APP alone would be able to meet that metric or that goal. And so I use productivity as, everybody that either loves work RVUs, hates work RVUs. I think Sue spoke to that because it's more than just the work RVU. So let's take an example of a physician proceduralist with an APP partner. Let's say it's GI, for example. Obviously, the nurse practitioner or PA, the APP, they're never going to be doing those procedures independently. That doesn't make sense. It's not part of the scope. The physician is able to do that. So you want to have the APP incentivized to help make the physician as productive as possible. And you don't want to penalize the physician for not being in the office. You want them to be doing what their best and highest use is being in their procedural suite. So if you set a productivity threshold or incentive for the physician, for the APP to be as productive as possible, then that puts both providers kind of on the hook for making each other successful and quote unquote win together. So setting those thresholds. Other examples would be part of the physician incentive is to make sure that their APPs hit a certain productivity threshold. And so then it reduces that duplicity of work that sometimes you see if there is a competition, because if the physician is incentivized on a work RVU, then you'll see them come back and do some of the exact same parts of the visit so that they can meet the compliance for billing should there be an audit. So it's really important that you don't want to set up that competition, that instead you incentivize the physician and the APP together to be productive. And it's only possible to hit that incentive if both are as productive as they can be.
Sure.
As far as including the incentive in our employment agreement for APPs, we do not. We actually outlined our employment agreement as closely mirrored to our physician employment agreement as we could. Our incentive plan is actually in a separate policy document, if you will, that we share with our APPs, and it allows that flexibility to change those from time to time versus having to go in and change the entire employment agreement language. And so it is a separate function, but the employment agreement speaks to that document. And our APP compensation committee this year, one of the big successes was that we created an APP compensation committee that is partnered with the physician compensation committee. So we move together. If there's something that impacts one or the other, we discuss it as individual committees and bring it back together as one whole committee, and we have shared membership between the two. So again, really important to align the structure, the framework, and even how those decisions are made, and aligning the employment agreement with the flexibility through policy documents we found to be pretty successful.
Thanks for that, Brittany. April or Susan or both, we often get questions, particularly from environments where APPs have not been plentiful or out front. I wonder what the patient response to seeing APPs is going to be, and be interested in any feedback you've had from your organizations of how do patients actually and families experience interacting with APPs.
Sure, I'll take that one first and then turn it over to Sue. But I think one of the things we do is we just educate as to the role of the advanced practice provider. So if we're talking about a nurse practitioner, which I happen to be a nurse practitioner, what is a nurse practitioner? And that is a nurse that's had advanced education and training to provide care for a particular type of patient. And so what is a nurse practitioner? So we really want to make sure that we're educating our patients, but also giving patient testimonials, if you will. If a patient has had an experience with a PA or a nurse practitioner or a midwife that they'd like to share, we really want to share that patient's personal story with other patients, because I think that speaks volumes. So it's really educating the public. One thing I love on the inpatient side is when we're rounding, I'll often be rounding with the inpatient team, and we'll go into the patient's room, and the attending or the physician on the team will say, this is April Kapu. She is our nurse practitioner, and she'll be providing your care today. If you have any questions, please ask her. So very respectful of one another's roles, and making sure that the patients are educated to what that particular provider will be doing in terms of providing and helping to coordinate that care. Sue?
Yeah, I would say many of the same things that April said, and would also add that I think in the team-based care model, and that goes from an APP in a primary care clinic with no physician physically present to, the cardiothoracic surgery team. I think the shared language about the role of the APP in each of those settings, which is of course a very different role, is really important. So we're educating the patients directly, but I think also the clinicians across the enterprise are very well versed in the role of the APP in the different subspecialties. And so they're able to know that, for example, we have a really amazing CHF nurse practitioner team here at Leahy. And so all of our colleagues across the organization are well versed in the skill set of those providers. And then the patients are thrilled to identify with their nurse practitioner who cares for their CHF. So I think that education is multifaceted and comes both directly and from shared experience for the clinicians across the organization.
So I have a little something to add to that. As part of our optimization work, we actually sit down with a patient focus group, and I had the opportunity to do that patient focus group with the director of advanced practice for our Cancer Institute. And so we asked specific questions about the role of the advanced practice provider, the role of the physician and other care team members. And we said, what do you see as comparing and contrasting what these roles are and what it means to you for these folks to work together? And it's a quote that I'll never forget, and probably the oncology nurse practitioner never will either. But one of the patients said, it feels like I go to the physician to treat my disease while the advanced practice provider is treating my soul. And to me, I thought that captured, that is what we're doing. We're working as a team together to medically optimize the patient, but also treat their soul and treat their patients and family members. And again, that's going to stick with me probably throughout my leadership career.
Thanks for that, Brittany. Wow, powerful stuff. We're getting close to the end on time, but before we do that, I thought maybe just we'll do a round robin and give each of you 30 seconds to comment on anything that you think needs to be said that hasn't been from your point of view. So maybe Ben, would you mind going first?
Sure. I mean, I think what I would add here is it's incredibly important. I think for the people who are listening to us or watching us right now, as they're planning their own advanced practice provider integration strategy, have to keep in mind the financial, making sure that whatever plan that you have for using the advanced practice provider has a very good financial underpinning, a good predicate, that if you're thinking of hiring an advanced practice provider, that you have a real strategy behind using them to their fullest potential. I very, very commonly, and I think the leaders on this call will probably agree with me, is that many organizations will have an idea of how they want to use their advanced practice provider, but it's not sort of in keeping with the delivery of regulated medical acts or providing, physician level access. So, the ROI, as you've heard today, I think is incredibly important when you're planning your strategy.
Thanks for that. Susan?
Yeah, I wholeheartedly agree with what Ben said, and I think if he hadn't said it, I would have said something similar. But I also would add that the value of these types of conversations, and I think you said it in the beginning too of the webinar, that our shared experience and shared ideas with each other, and for those of you who are watching us, there is no more value than us conversing with each other about our ideas, and something that works for Brittany's team may not work perfectly for my team, but I have found sorry about my pager, I found a spin-off idea from speaking with Brittany on a continued basis. And so there's so much value in sharing our ideas. And like April referenced, the state laws may prevent us from doing certain things exactly the same way, but there's so much value in learning from each other and iterating because it's different year to year as well.
30 seconds, April.
I would just say, as organizations are learning more about how to incorporate advanced practice, to really to lean in and get to know exactly what an advanced practice provider does, get to know more about their education, their training, their outcomes of care. So read the literature, talk to other physician and nursing leaders and advanced practice leaders, and find out exactly what the value contribution is to their teams and to their patients. Really just ask, lean in, find out more about what advanced practice has to offer.
And Brittany.
Yeah, I think that this work is critical for us to win as a society and moving healthcare forward and meeting the patients where they need us. And it's going to take the entire team to do so. It's not going to be just accomplished. There's not one solution or one lever that we can pull. So I would invite, as April said, to really ask the nurse practitioners, PAs, our other advanced practice colleagues, what is it that you aren't doing that you could be doing, and how do you want to contribute to making this work, and what are your ideas to doing this better? And it really starts at the top of the organization, right? Because there are still cultural forces out there that are trying to prevent, whether it's fear-based, whatever that is. We really need our C-suite members and our physician leaders and nursing leaders to really lean in and break down those barriers and put all that aside and really work together towards the common goal, knowing that we all need each other to win and to be successful.
Well, I just want to amplify that, Brittany. I get asked a lot, why does the Chartis Group, why do the organizations represented on this webinar feel so strongly about this being an important strategic direction? You've each talked about what a great contribution to the triple aim, all aims this can be. But even if we're just thinking about cost, there are 1,000 little levers to pull around substantially improving the cost of the care we provide, but there are very few big ones. One is adapting technology significantly differently than we ever have. Obviously, there are gains that can be made in a value-incented environment, but innovating on the care team and tapping the value of APPs, in our mind anyway, is a huge early lever to be pulled across the country. And we would love to see more gain the value of what you've already been out there doing. I want to repeat what I said earlier in thanking each of you for your precious time. Your voices are important, and we appreciate the opportunity to amplify them. For attendees, you will get a follow-up email to this that has our article linked to the bios from each of the panelists, some other information, and to survey you about these types of endeavors. About a week from now, there'll also be a recording of this event available, so look for that as well. We very much appreciate you sticking with us through the hour. I thought it was great, folks, so thanks for the contribution that you've made. And with that, we'll end the webinar. Have a good day.